Good afternoon, everyone, and welcome to today's PHO Rounds, which happens to be on March 3rd and also the third of an incredible webinar series on Black health that we launched at the beginning of the year. Today's session is called A Collaborative, Responsive Innovation Model of Care to Address the Impact of HIV on African, Caribbean, and Black communities living in Ontario. My name is Samia Abdi, and I am a Senior Program Specialist at PHO, leading the Health Equity File. Before we start, I just wanted to take a moment to not only acknowledge the land that we're in, but also remember what has happened in this land. So I am very honored that I am joining today from Toronto, Toronto. This land has been the land of many Indigenous people, including the Huron-Wendat, the Anishinaabe, the Chippewa, the Haudenosaunee Confederacy, and most recently, the Mississaugas of the Credit. It also continues to be home to many Indigenous nations from across Turtle Islands, including other First Nation and Inuit and Métis people. We acknowledge and recognize the impact of colonization, not only the historic impact, but how that colonization continues to disproportionately impact Indigenous communities in terms of loss of language, culture, ways of knowing, ways of healing, and most importantly, sovereignty of Indigenous people. At the heel or the conclusion of Black History Month, I also take a minute to recognize that for centuries, millions of African people were forcibly uprooted and brought to Canada against their will to generate wealth for European settler colonial societies, and those who ended up on this land suffered an unspeakable acts of dehumanization, brutality, violence, and torture, as well as death. It is our responsibility as public health leaders, practitioners, not only to acknowledge those historic facts, but to live our lives and act within our roles in society and within our professionals in ways that upholds Indigenous sovereignty and supports and fights for Black liberation. I wanted to just start with a few housekeeping notes. Please note that to increase and optimize our experience today, that the Zoom chat and audio and video features have been disabled. However, we do have a Q&A function, and we would love to hear your questions, your comments, your suggestions, your resources as we go through today's session. If for any reason you're having any technical issues, please do email our capacity building team, capacitybuilding@ohpp.ca. So getting right into it, it is my honor to introduce our incredible, powerful speakers for today's session. First being Nadine Sukurmani, who is the Chief Executive Officer of Ontario HIV Treatment Network, who has over two decades of senior leadership in the nonprofit sector. She brings a lens around health, equity, accessibility, gender-based violence, and HIV. She is a change agent working tirelessly to end all forms of racism and oppression. Nadine's extensive experience includes roles as the executive director at Women's Health Clinic, Five House, where she championed initiative as the STBBI prevention, housing, harm reduction, and reconciliation. Nadine is also an adjunct professor with the Community and Social Services program at George Bryant College, and she is an incredible, passionate, community-based HIV leader that focuses on harm reduction and continues to bring that passion to everything that she does. Next, I want to highlight our next speaker, who is Lydia Makoroka, who is the Senior Director of Programs at the Ontario HIV Treatment Network. She leads the strategic projects that center around collaboration, health equity, community engagement to drive change and improve the health and well-being of people at risk and those living with HIV. Most of her work continues to focus on anti-oppression and social justice initiatives. She also holds a graduate degree from McMaster University in health research, and she has spent over 20 years leading various HIV, LGBTQ plus initiative, working on implementation science and community-based research and evaluation. Finally, I would like to introduce Dr. Notisha Massaquoi, who is an amazing community leader. Dr. Notisha is an assistant professor in the Department of Health and Society at the University of Toronto, Scarborough, with a cross appointment in the Factor in Wantash Faculty of Social Work and Timir III Faculty of Medicine. She is also the founding director of the Black Health Equity Lab, which conducts community-based health research and partners with Black community to develop advocacy tools, strategies, programs aimed at improving health outcomes and well-being and success within Canadian systems. Earlier in her career, Notisha had played a pivotal role in establishing several health organizations serving Black communities, including Africans in Partnership Against AIDS, Taibu Community Health Center, the first of its kind serving Black communities in the GTA, and most notably served for over 2 decades as the executive director of Women's Health in Women's Hand, the only community health center in North America providing a specialized primary health care for Black and racialized women. We have a star roster today. Take it away, Nadine.
Thank you so much, Samia. And yes, we do. This is very exciting for not only us at the OHTN, but also on behalf of the communities that we are here to represent. So just to start with our disclaimer, this presentation was created by the OHTN and Dr. Massaquoi, and we are an external organization to the Public Health Ontario. It will be published on the PHO website for public use as outlined on the website terms of use. PHO is not the owner of the content. Any application or use of the information is the responsibility of the user, and the PHO assumes no liability resulting from any such application or use. So we have nothing to disclose, and so we'll jump right in. We have a number of learning objectives for the time that we're spending here today. First, to describe the HIV epidemic in Ontario and how it disproportionately impacts what we say ACB, African, Caribbean, and Black communities in Ontario. To describe some key HIV testing and clinical care landscape activities available to ACB communities across the province, identify core components of an innovative HIV clinical model. We're really excited to hear about this model and share it with you, designed by and for Black people living with HIV, describe the challenges faced and solutions implemented to maintain trust and collaboration with ACB communities in the context of HIV services, and finally, to consider how to apply these strategies to promote equitable access to HIV clinical care and related adaptations to advance health equity in your own public health practice. So again, just the overall outline, we'll start with the HIV response in Ontario, and Lydia will share some of the 2024 epidemiological trends that we're seeing, and we'll speak to the HIV prevention testing and clinical care landscape. It feels like I'm going to be jumping over those words all the way through this, so bear with me. And then Dr. Massaquoi will share the innovative HIV clinical model of care that we are so excited to support at the OHTN. So first, the HIV response in Ontario. So the OHTN, the Ontario HIV Treatment Network, our mission is to improve the health and lives of people living with HIV in Ontario. We also predominantly focus our work on data and evidence to drive change, which is, again, what we'll be sharing. The OHTN Collaborative, which is the Ontario HIV Epidemiology and Surveillance Initiative, is a collaborative partnership. It involves Public Health Ontario, and again, thank you for inviting us here today, the Ministry of Health, Public Health Agency of Canada, and of course the OHTN. And this group is has been working on the development and dissemination of HIV epi data across Ontario and beyond. So I'll hand it over to Lydia to take us into the data.
Hey, thank you, Nadine. And so the data that I'm about to speak to was kindly put together by the technical working group of the OEZ Collaborative. And a special thank to Austin Zeigmuth for his support in creating these slides. So before I speak to the data, what I would like to do is go over some definition. And so in Ontario, we have a particular way of categorizing HIV diagnosis. One is that we talk about first-time HIV diagnosis and previous evidence of HIV. And when we talk about first-time HIV diagnosis, is really talking about people who learn about their HIV status for the first time by having an HIV test in Ontario. So this means that they haven't had any report of a previous HIV diagnosis being inside or outside of Ontario, and they don't have any history of a viral load testing in Ontario. On the other hand, when we talk about previous evidence of HIV, we're really talking about those who have a first-time positive test in Ontario, but do report having a prior positive test outside of Ontario. Or they've had a previous history of HIV viral loading in Ontario. And these definitions are important because when we look at the new cases of HIV, it gives us a greater sense of who are the true new diagnoses versus those who might actually have a previous evidence of HIV. What I would like to do next is talk about the Look Back project. Next slide, Nadine. And so the Look Back project, the reason Oh, thank you. The reason I would like to talk about this project is because it was a unique project that took place in 2024 to contextualize the 2023 data. As I mentioned earlier, the categorization that we have around first time and previous time of HIV is due to the fact that the Ontario HIV Surveillance Program data is submitted by clinician and provider when ordering a test. And what we know is that for some of the first HIV time diagnoses that are ordered by the provider, the form are sometimes incomplete and do not have all the information, leading to missingness in the data system for key variables of interest. And so in 2024, there was a data quality project that was undertaken, the Look Back, the HIV Look Back project, and it was done to better understand the significant increase in HIV diagnosis that had been observed in 2023, and in order to improve the missingness in the data. The method that was used was to go back to select public health unit and ask them to supplement additional data that was missing by taking a retrospective review of their data system. And what some of the key findings too is that one, we were able to reclassify reclassify some of the HIV first-time diagnosis as previous evidence of diagnosis, effectively decreasing the number of first-time diagnoses from 938 to 723. And also we were able to determine that by looking at the data and doing subsequent analysis, that the missingness was actually random, which gives us more confidence in the data, despite the missingness, with only one exception, which was the variable around sex, where there was a range of 5%. So now with those definitions, what I would like to do is then walk you through some of the trends going back to 10 years. So first of all, when we look at the number of first-time diagnoses in Ontario in the last 10 years, we see that between 2015 to 2019, the numbers of first-time diagnoses were relatively stable. And then we do see a decrease in 2020 2019, 2020 to 2021, which represent the COVID years. And then we see an increase back in 2022, 23, and 24. And as of 2023, when you look at it, you see that shaded area that I highlighted 202, and that's to represent the look back project and how the numbers were reclassified. And when we look at 2024 in particular, we see that we have 865 first-time diagnoses, which is a decrease of 6.5% compared to the previous year. Next slide. When we look at the rate of first-time HIV diagnosis per 1,000 people, we see a similar trend, fairly stable, 2015 to 2018. We see the impact of the COVID-19, and we do see that decline in 2024 compared to 2023. So the rate being at 5.4. And again, you see that dot of 4.6. If we account for the look back, that's what the rate would be. And without the look back, the rate is at 5.9. Next slide. So now I'd like to switch gear and talk a little bit about proportion of first-time diagnosis. And this is when we're looking at various characteristics, such as I'm going to look at sex, region, and then also talk about race, ethnicity. So when we look at the proportion of first-time diagnosis by sex in the last 10 years, what we see is that the greatest proportion of first-time diagnosis was accounted by male, and you see that being at 69% in 2024. And you also see that it's a bit of a decrease. However, the proportion among female has steadily increased over the past 10 years, and you can see that it's at 30% in 2024. When we look at region, what we see is that, again, looking at the proportion of first-time diagnosis, the largest proportion of first-time diagnosis in the last 10 years has been in Toronto, although we do see a decrease since 2020, and now we're at 40%. And what we also note is an increase in two regions, in particular Central East, from 10% to 25%, as well as Central West from 8% to 15.3%. And the proportion of first-time diagnosis has remained stable across the other region. Now, when we look at race ethnicity, which is information that's very relevant for this talk in particular, is that we do see the proportion of first-time diagnosis among Black individuals has increased steadily, going from 22.6% in 2020 to 38% or 38.9%, close to 39% in 2024. Effectively becoming the largest, Black people becoming an individual, becoming the largest reported group by 2023. And interestingly, we also see that the diagnosis, looking at proportion again, among white individuals has declined substantially over the same period. So going from 37.7% in 2020 to 23% in 2024. Now, some of the data that we've presented before, looking specifically at the 2023, when we look at this proportion of first-time diagnosis by race and by sex, we do see, in particular for Black women, a greatest proportion. In 2023, that proportion was at 70%. And now turn it back to Nadine. Oh, before I do so. So in summary, just highlighting that as of 2024, where we are in terms of the first-time diagnosis, we're at 865, which is a decrease of 6.3% compared to the previous year, 2023. We do see that the proportion of first-time diagnosis is increasing among women. We see that by region, Central East and Central West have an increase in the proportion of first-time diagnosis, although Toronto remains the largest, accounts for the largest proportion. And when we look at race ethnicity, we do see that Black accounted for the largest proportion of first-time diagnosis.
So when we talk about this data and we share it in particular around the topic that we're speaking with you about today, I want to just touch back on the last point that Lydia mentioned, which is that folks who identify as African, Caribbean, and Black disproportionately show up in the HIV data at alarming rates. And we say alarming rates, and this is really back to what we know around the racial disparities for Black populations across the country. So not specific to HIV, but HIV being that layer or again reflecting the disproportionality. So you'll see here that Black and racialized communities, we know, and I think collectively in this group, not only those of us presenting, but those of you who are joining this and as public health providers need to acknowledge and must acknowledge that the disparities around access to healthcare and the historical violence, what we talk about the impacts of colonialism, but also a system that was built to benefit those who do not look like Black communities in our country. So we're not seeing that much. There's not much difference when it comes to HIV, the disproportionate ways, and that's an important word. When we talk about data, we talk about proportions, but when we think about the disproportionate impact that these inequities are having and the life impacting ways that this shows up for HIV, we absolutely need to consider the economic and social conditions, such as health status, income, education, employment, housing, and experiences of discrimination. And I think I hearken back to last year at the Canadian Association for HIV Research conference that took place in Halifax, and Dr. Massaquoi, Dr. Winston Husbands, Dr. Lawrence Wawa all spoke to this so clearly, and it was shared across attendees, researchers, epidemiologists, scientists, that this is not something that we can ignore any further. So the social and structural impacts and determinants of health are really at the core of why we're seeing what we're seeing for those living with HIV in Ontario. So when we talk about this and we ask the following, or we ask the question, what can we do for ACB people at risk or those living with HIV? We must identify how anti-Black racism fits into the overall picture around those structural and social determinants that I just shared. We must talk about and address the increased risk across all of the systemic issues. And I'll talk not only the model that Notisha will be speaking to, but also what we're doing at the OHTN around increased risk and prevention and interventions that can be implemented early in the pathway towards getting ahead of the current situation that we're in Ontario. We need stigma-free healthcare experiences. And when we talk about stigma, we're talking about the quality of life, the ways in which how individuals access it, back to that lack of access or the ways in which people access. We hear every day, and this is not an exaggeration, that people who engage with the healthcare system are experiencing anti-Black racism, not only at the first window that they walk up to, but with the person who may be drawing blood. This is for HIV a particularly important moment that people experience and have seen the way stigma shows up. Then you move into the next step where you're dealing with the healthcare practitioner. And so at every step along the way, that stigma can and does in fact impact people's experiences. We need better, faster linkage to care, which is what Notisha will speak to, and we can also highlight in our closing remarks. Increased and lower barrier access to PrEP and PEP, which is pre-exposure prophylaxis and post-exposure prophylaxis. And this is really around harm reduction treatment and again, closing the gaps around people testing and then showing up in the data that Lydia shared with us. More access via primary care physicians as well as other healthcare practitioners, not just HIV specialty docs. And this is where, again, the OHTN is working very closely with looking at primary care as a pathway in, and community health centers like Taibu being another one of those examples. And then that community-centered healthcare with increased access to all health and social services, back to those structural and social determinants. When people are not housed, when people are not fed, when they are not employed, and there are so many ways that their quality of life is diminished and or impacted. HIV is not at the top of that list. And so we are focusing in that regard in a number of the initiatives. So as I shared, the PrEP scale up is important. We are engaged in culturally competent PrEP delivery via Taibu and Women's Health in Women's Hands. For those who aren't familiar, it is Notisha actually was executive director there for many, many years. And I will say an absolute change maker in in not only increasing knowledge and treatment, but access to care for Black women living with HIV through their model. Prep Start, which the OHTN is involved in delivering, which is a scale is providing PrEP to those who are not, who do not have adequate insurance or the availability of PrEP through a particular healthcare plan. So this is for those who are do not have documentation or unable to have those services covered. We have targeted HIV testing initiatives through our Get a Kit program, rapid HIV testing at HQ, and our No HIV campaign. So if you'd like to know a little bit more about HIV and the work that's happening across the province, please visit KNOW, to learn a bit more. And then the final ones we'd like to identify are around targeted HIV clinical care. So again, through HQ. HQ is a GBMSM focused clinic that is doing incredible work with Black and racialized communities, and again is key to acknowledging that GBMSM are still gay by men who have sex with men is still the largest group of folks impacted by HIV. Within that group, we acknowledge, as the data shows us, that Black men and racialized men are showing up in that data at disproportionate rates. Blue Door Clinic, which is a clinic that offers care, HIV care specifically to those who are uninsured, and is located at Casey House in downtown Toronto. And of course, the Aya Circle of Care, which you will hear more about shortly. And with that, I'll pass it over to Notisha.
Fantastic. Thank you. Thank you again. It's always a pleasure to partner with the OHTN. And I always like to give a vote of gratitude to the OHTN for believing in the research that I do with the Black Health Equity Lab. I'm currently a professor at the University of Toronto in the Department of Health and Society, and the Black Health Equity Lab is located within the university. I do want to start by saying that I had been invited to come and speak to PHO about 7 years ago to take a look at anti-Black racism and how we need to address it within the public health realm. My workshop was canceled, and I was upset. I'm like, why is it canceled? When are we rescheduling? And I was told, well, maybe a year from now. I'm like, okay, these people are really resistant to doing this work. Little did we know it was because of COVID. And so I forgive you. So I'm now back after all of this time with something really exciting to share with you, which is the Aya Circle of Care program that's located at Taibu Community Health Center. I always like to feature my students that I work with, because the focus of our lab is to take a look at the disproportionality when it is expressed within the Black community in terms of healthcare and HIV. As you can tell, we make up 4.3% of the provincial population, but 39% of the HIV cases in the province. And so as students, we wanted to take a look at why, but not just why, what can we do about it? And next slide, please. One of the things that we learned through the COVID pandemic is just looking at where the COVID cases were occurring in relationship to the Black community and where we were living. And I know all of you have probably seen the maps of where COVID was showing up, and it mapped exactly in terms of where the larger populations of the Black community were living. We took a look at those maps and thought about them in relationship to HIV. And one of the things that we noted was that in that red circle on the map of the city of Toronto, where about 93% of all of the HIV services for the GTA are located. versus the brown areas, and the darker the brown, the more Black people live in those neighborhoods versus where Black people were living. So one thing that was very notable to us was how far Black community members were traveling to get to HIV services. The other thing that we noted, which Lydia highlighted, the two areas that had some of the largest populations of people living with HIV were Central East and Central West. They also have the largest Black populations. And so, next slide, please. When we took a look at the map of the city in terms of where people were traveling from, in terms of Black people to get HIV services, you can see that Central East and Central West have the largest proportion of people traveling downtown for services. When we took a look at Central East in particular, because that's where our lab was located, and the Scarborough region, the Durham region, we have the highest population of Black people and also the highest population of people traveling downtown for HIV services. But what's notable is that there were no HIV services in the Scarborough region, none. So if you tested positive for HIV, you had to travel all the way downtown for all of your HIV specialty care. Now, we understand that distance from health services is an incredible barrier and cost for people to access care. It is probably one of the greatest factors that would determine whether someone will stay on treatment, how successful they are on their HIV treatment, and how successful they will be in terms of suppressing the viral load. Next slide, please. So one of the things that we wanted to do is look at geography and look at neighborhood-based solutions. So what would happen if we placed a primary health care clinic specializing in providing HIV services to the Black community in the Scarborough region? And what if we took a look at how that service was delivered? So not just any kind of service, but one that was customized and designed specifically by Black people living with HIV for Black people living with HIV. And the OHTN very generously funded a pilot program for us to take a look at primary health care, a primary health care HIV program for Black families, because that was another issue that we had. HIV services were geared based on gender, so women's serving organizations or ones that were focused on men, but not looking at whole families in terms of how we could provide services across an age continuum. So our pilot clinic that we designed had 4 goals: to lower the percentage of Black people living with HIV who are not linked to primary health care, to lower the estimated number of days it takes for a newly diagnosed person to start medication and to receive that first viral load test, and to lower the number of days it takes to reach viral load suppression. We understand that with a suppressed viral load, someone cannot transmit HIV to people they love. And what if we could suppress viral loads in whole neighborhoods of people with high rates of HIV? What impact that might have in terms of addressing HIV specifically with Black communities. And we wanted to lower the burden of the social determinants of health that Nadine very eloquently discussed earlier. So the burden of the social determinants of health on Black community members living with HIV, and to reduce the barrier in terms of them accessing healthcare on a regular basis. Next slide, please. We approached Taibu Community Health Center because they already had expertise in the Scarborough region in terms of providing care specifically for Black people, but they were not providing HIV services. So it was a big ask to ask a clinic to now begin providing HIV services, but understanding that as a research team, we were going to support them to be able to do that. And to provide family-centered care in a holistic model that was an Afrocentric model. And Taibu specializes in providing healthcare from a very specific way of dealing with anti-Black racism with Black communities in terms of increasing their access to primary health care. Next slide, please. They very kindly suggested that I change the name of a very long clinical name that we had for the team and branded it the Aya Circle of Care. Aya means strength. Um, and the fern is a symbol of strength in Ghanaian culture, and so they wanted it to be something that would resonate with Black community members. If you get a chance or you're interested, they do offer supporting clinicians and people who are working in the field opportunities to come and visit the clinic at Taibu. Next slide, please. It was really important that this program was designed with and for people, Black people living with HIV. And so we had an expert community advisory committee guide us through the design and the development of the program. They helped us in terms of selecting the clinical staff. They supported us in advertising the program. And what became very evident is that this team of experts who are people living with and working with people living with HIV was that they not only helped us get started, but they supported us throughout the whole development of the program in terms of providing support for the clients as well coming into the program. Next slide, please. The model is based on this initial team that provides intensive case management, meaning only approximately 20 people will be on a caseload at any given time. And as people become stable, the viral load becomes suppressed, then they come off the caseload of intensive case management. There's a community nurse practitioner, there's an advanced practice nurse, the peer navigator who's helping people navigate the social determinants of health, and a case manager who's a social worker who's helping with mental health support and deal with life challenges. This is the initial framework of the team, and this is what was funded by the OHTN, and this is what we believe would provide intensive case management effectively for Black people living with HIV. Next slide, please. This is the team in real time. This is who they are, what they look like. It's very important that we had a team that was representative of members of the Black community, provide services to people from the Black community. Next slide, please. Our first caseload of 25 took us about 18 months to get to a place where we were providing consistent care that we could replicate. And it was really important from a research perspective that we weren't just making this up as we went along. We wanted to provide a model that could be replicated, and we understood why it worked. The age range was from 1 month to 78 years. You can see some of the challenges that our clients are having. But despite the socio-demographic nature of the challenges that our clients were having in this first caseload, we were able to have 100% retention in care and 100% viral load suppression. So the program was extremely, extremely effective. I have a picture of our first baby that was born in the program, and mom was extremely high risk, and we were able to guarantee a Black mother that her baby would be born HIV negative. And in recognition, mom named her baby Aya after the program because she was so grateful for the support that she was able to receive from the program. Next slide, please. Reality kicked in, and the first iteration of the ICM team that I showed you wasn't the one that we needed in reality. And so an HIV specialist was added. Also partnerships with external partners, particularly Public Health in Scarborough, for example. And also that expert advisory committee needed to stay with us throughout the entire program. Next slide, please. Essentially, someone would be referred to our program. Within 72 hours, they are referred to a nurse who would provide case coordination, the initial assessment. They would be in care within 72 hours of that referral. And they also would receive follow-up cares within 24 hours of that first initial visit. And that happened for every single client who came into the program consistently. Next slide, please. It was very important that we were able to replicate this model so that 72 hours you were in care, you were seen by a multidisciplinary team. Within 24 hours, we were following up with you, that we had very specific, culturally specific pathways for you to follow, that we were tracking the data of every single client from the time they called until the time they were off the caseload, and that they were engaged with peer and community support throughout this entire process. Next slide, please. Next slide, Nadine. Next slide. Fantastic. You can see that we've seen 235 clients over the past 2 years with this model, 100% retention in care, 97% viral load suppression for our clients. And because we're tracking the clients so intensely through intensive case management, we know exactly who has not been able to suppress viral load and the reasons why, and then what supports we can continue giving that person until they are able to reach viral load suppression. Next slide, please. I'm going to pass things over to Nadine because I've gone through what the model should look like and understand that our goal is to replicate this model, and we'll be scaling up the AYA Circle of Care to 4 other sites across the province over the next year.
Thank you, Notisha. So exciting. And I have to say, I had the absolute pleasure of meeting baby Aya and her mom when I visited. And it was even as you share that story, my heart is full. Thank you so much. And yes, the OHTN is committed to, and the Ministry of Health, expanding this model across the province, and so more to come around that. So some of the emerging best practices that Natisha has shared is the rapid referral and linkage models, the 72-hour model, that best practice for linkage to care, and that is what our goal is as well at the OHTN across the clinical services that we provide in our partnerships with organizations across the province. A multidisciplinary intensive case management, of course, the cultural safety as core practice, peer leadership, data-driven coordination, community-led evaluation, and replication pathways, which is again back to what we're hoping to achieve. So our final considerations, folks, so we can allow some time for Q&A, is the acknowledgement that HIV is an issue affecting every part of Ontario, that the proportion of first-time HIV diagnosis among Black people has increased, and it requires a coordinated, continued, and collaborative response. So we're bringing a challenge to you today to share with us, whether actively today, and we will follow up in, I think, either 3 months or 6 months, and we'll work with PHO to figure out a way to do that with those who are here. How will you become a player in the strategic engagement of public health as part of the HIV response to Black communities? What can you or are you doing in your own settings? And this is a call not only to practitioners, but to the public health units, to our community partners and beyond. It's important as well that you identify opportunities for alignment. So how can you, in your role within the public health sector, optimize the HIV response for Black communities? We at the OHTN are committed to this. We know that the OHISI Collaborative and the folks that we're working with are also committed. And in order to make change in the current systemic issue around HIV and public health overall, this is absolutely necessary. So we're sharing this information with you for awareness and education, but also action. And we want to acknowledge the technical working group of the OHISI Collaborative. You'll see them here. The AYA Circle of Care, Dr. Massaquoi, Lieben, who's a dear colleague, Taibu, as well as the OHTN, which is Lydia, myself, and our entire team, and the Ministry of Health. So thank you all for your attention today. And I think we'll now open it up. I believe it's time to stop sharing, and we'll go to the full group.
Thank you all. That was incredible. Lydia, Nadine, Dr. Notisha, that was incredible. So folks, as you are thinking through, if there are any questions, comments, please send them through our Q&A pod. I also wanted to congratulate you on that amazing program, the Aya program. And as you were sharing the name, in the Islamic tradition, Aya means evidence. So it's incredible that this is an evidence-based, rigorous program that provides not only scientific and theoretical knowledge, but actually practical knowledge, and is actively changing people's lives. So as we are getting questions, I wanted to ask you, Nadine and Lydia, in the Look Back project and seeing that jump in cases, particularly around Black women, have you also look into the why? Like, what are some of the root causes for that change in the cases in terms of the higher new cases?
I'll hand it over to Lydia to talk a bit more about the look back, but I think it's really important. I mentioned stigma earlier, and it's really important to understand how, for example, heterosexual women, Black women, racialized women interact with the healthcare system, and how willing are we to share who our partners are, who are we sleeping with. If we happen to be a member of the 2S LGBTQIA community, or bisexual, or our partner is a man who is having sex with men, we may be aware of that, but that is not something that we feel like we want to share with our healthcare practitioner due to sex shaming, slut shaming, as well as the cultural implications that may have, and we may also be coming to terms with that ourselves. So I think that the missingness in data is related to how and what people share with their healthcare practitioners. And for me, and I know for others, it comes down to trust and relationship. And if you have relationship or in relationship with your healthcare practitioner, you're more likely to share, and then you'll have access to PrEP, for example, and you may have access to the tools that you may need to mitigate the potential life-changing impacts HIV has in your life. Lydia, maybe more specifically the look back, if you don't mind.
Sure. And what I would say before I even talk about the look back is qualifying that typically the rate of HIV may vary from one year to the next for various reasons, right? So let's say if there is a spike in testing, we might suspect that we would be able to locate new cases, right? If there are issues around, if there is a pattern around migration, whether it's from one province to the other or external, we might also be able to pick up new cases, right? So there is a number of things that we expect to see from one year to the next. The look back in particular, the reason that project took place is because when we were looking at the form, the testing form and the information that allows us to qualify not only some of the key indicators around race, ethnicity, but also age, sex, as well as region, there was information that was missing. And so it was very difficult to be able to really give a clear picture of what was going on. So the numbers that I'm able to tell you right now in terms of the 38% for Black, we couldn't necessarily say what that number looked like, or there was a number of missingness, as well as country of origin. So the look back allow us to go back and get additional information so that we could actually get a better sense of what's going on. But it was also a project that was reassuring in that when we looked at the pattern of missingness in the data, we did notice that it was random. And so that still gives us confidence that even with a certain level of missingness, we can trust the data that we have, right? Obviously, we strive to do better. We want to make sure that the data is as complete as possible. And so this is a call out to any physician or anybody who's done and completed a requisition form to really take the time to complete those forms, because it's important, and it gives us additional data that also help us inform the response as well, and programming down the line and policy. And I'll stop there. I see there are other questions.
Yes, thank you so much. And the questions are coming in. So the first question is for Notisha. The question is around knowing that the caseload is 25 people and up to date 235 have gone through the program. Does that mean that they have moved on to less intensive program? And in terms of like the follow up with those who've gone through the program?
So yes, technically, but the the uh, the system navigation has been really challenging, and so clinically, they don't need the intensive case management, but housing has been a big factor, immigration issues has been a big factor, like all the other social determinants of health um, hasn't allowed people to technically come completely off the caseload. So, again, this is where we have to tweak the model. Our goal was to get the viral load suppressed and stabilized and to keep people in care, engaged in care, which has been extremely, extremely successful. But we didn't predict that there would be a housing crisis in the GTA. Like, there's things that we couldn't account for. But I think the understanding that the team is embedded in Taibu, and so now we've also provided supports for the rest of the organization to continue supporting the clients. So they may come off the clinical intensive case management at Taibu, but they stay in that health center and get all of the other supports that they need. So that has been an extremely important, um, I think, dimension of the model that one has to think about as we replicate it in other locations.
Excellent. And thinking about sustainability and also continuous care for folks who are part of the program. The next question is also related to the circle of care. And the person is particularly asking where African people of African descent are a minority and therefore perhaps do not have clinical provider representation. How would that model might work in the absence of the basis of this being a really Afrocentric way of doing the work?
So in geographies where Black
Mm-hmm.
people are small in number, that's extremely important to address because what tends to happen, or what I saw, especially when I was at Women's Health and Women's Hands, is that people would travel great distances to come to our clinic. So we had our clinics located in downtown Toronto. We had people traveling from Grimsby, from St. Catharines, from spaces where they weren't getting culturally specific care or supportive care. I think one of the things that we have to work on in those spaces are the providers who may not be identifying as Black need to understand what culturally competent care looks like. How are they connecting with models such as a Taibu? And what are some of the remote supports that can be provided for clients? What are some of the peer supports that could be provided um, in the spaces where uh, they don't see providers who look like them? Because we still need them to get their clinical care. But maybe some of the other cultural aspects of care, Afrocentric care, can come in other formats. Those are things that we've also been working with, especially at Taibu. They've been doing some remote work, remote support groups, um, and
Mm-hmm.
remote peer support. So it's the collaboration. But I heavily rely on providers to understand what's missing, what might be missing for their Black clients if they themselves don't identify as Black. Like research has shown that racial concordance is the one of the greatest success
Mm-hmm.
factors for Black people in terms of addressing chronic illness. So, if you do not identify as Black and have Black clients, what are you doing to make sure that you're mitigating the difference, the discordance that might occur?
Mm-hmm. Yeah, if I may, I'd just like to add, this is also related not only the clinical care, but the Natisha, you also shared the importance of peer support, peer navigation. So when we look to the more rural parts of Ontario where there may not be as dense a Black population as we have in Toronto or Scarborough or Peel Region, for example, we are also relying on the local HIV community provider. So that would be what we call an AIDS service organization. And across the province in Ontario, and folks may not be aware of this, there is an organization that is Provincial's ACHO, and ACHO has workers, Black workers who across the province who support individuals in the AIDS service organizations across the province. So we will also be at the OHTN coordinating, and that's a role that we play, is to ensure that and there's a question there, if I may jump to it, can you share the 4 places where IO will be expanding to? So short of naming where we intend to do it, I will share the areas that we're looking at. So there is intention, and actually we're quite close to a location in the Etobicoke Peel region. And this is actually connected to a presentation you folks had recently. So I'll leave it there. And then Southern Ontario is another area that we're focusing in on, as well as I'm gonna say Northern Ontario, not true Northern Ontario, Northwest, South, I don't know what you call it, the northern quadrant of Southwest. So, just to keep it a bit general in that we're really comes down to, Notisha, what you're sharing is we need to ensure these organizations are ready. So we've been doing readiness assessments with them beyond training, because cultural competency training is not enough. Taibu is a unique example where they already had the Afrocentric model embedded in their work. We will need to be bringing these organizations into a place where they can. And so again, the next site that we will be funding has shown their ability to focus in on Black communities. So that announcement will be coming shortly. And so stay tuned. That's all we can really say right now, unfortunately.
No, that's really helpful. It seems like there will be a bit of geographical diversity of the program, and definitely ways that the program is being scaled up. The next question is really for all of you, and it's asking about your experience of how hard or how easy it is for newcomers to access HIV care post-arrival in Canada.
For me, it's the delay,
Mm-hmm.
right? It's the delay between arrival and learning about the services, where to get services, getting connected, or getting the referral. And one of the things that we're trying to do is significantly reduce that delay, because oftentimes people don't travel with their medication, especially if they are coming as refugees. You don't have your medication with you, and so you arrive and then you're off your HIV medication, and that's where the viral load um, no longer is suppressed. So, I mean, Nadine and Lydia can speak to it from more of an epi perspective, but for us, it's really about what are the points of arrival that we can connect with so that people know about, getting the referral to HIV services and programs like Taibu.
Mhm. Yes, and to build on what Notisha just shared, I think my response was going to be depends, because I think there is another element. If people are not aware of their HIV status and they're diagnosed through the immigration system, then it's an even greater challenge in that case. But it goes back to what Notisha was saying in terms of that connection and linkage to care and understanding the pathway and being able to access services, like knowing where they are and that warm transfer that could happen from within the system, the IME doc in particular, is a bit of a challenge. But this is also something that we're paying attention to at the OHTN, and there are a number of initiatives as well that we've undertaken to try to better understand where are the gaps and how we can actually address those gaps, whether it's through education and capacity building, or whether it's through piloting innovative program that can ensure a prompt linkage to care. There are a few initiatives that Nadine has spoken to earlier, such as the availability of services such as the Blue Door that connects that does an excellent job in terms of that linkage to care, but also HQ, thinking about access to treatment, whether it's treatment, but also access to PrEP. And so there are a number of initiatives that we're implementing and looking to, and that's really with the idea of closing the gap.
Yeah, this is where the intensive case management becomes really, really crucial because of the time required to get somebody, not just in terms of get them on treatment and in clinical care, but what are all the other things that you need to address for a newcomer who's just arrived, especially if they've just arrived with family. Taibu staff are dealing with getting the kids in school, getting, winter clothes, getting, all these other things that are just as important as their HIV treatment.
Amazing. So it's HIV treatment is not only about the treatment, it's a comprehensive way of looking at the individual and their families and loved ones as well. Uh, Thank you so much, Dr. Notisha, Nadine, and Lydia. This was an incredible conversation, and we are really grateful for your time. Thank you, everyone, for attending today with us. The session is recorded and will be available at the PHO website. And our amazing capacity building team, thank you for your support. They will also be reaching out to you. We are putting together a resource list throughout the Black Public Health series, and we'll be collating the resources that are shared by our various speakers, and we'll be sharing them with you. And as Nadine said earlier, we will be holding you accountable. We will be checking up on you to see how are you applying these learnings, because we are definitely not interested in learning for the sake of learning. We're interested in learning for the sake of doing. Thank you so much, everyone. Have a wonderful rest of your day.